Okay, now that we're recording, I'll go ahead and start this meeting to order. And Jolene, do we have a quorum?
We do.
Great. Okay, so the first order of business is to review the minutes from the prior meeting on March 28th. Oh, sorry, to review the agenda.
Madam Chair and members of the board, there are a couple of items that when we get down just past the board training, would like to add to the agenda. There was a request from board members to discuss the Horse Creek Hills ruling out of Broadwater County just briefly and what that means for public health and the work that we're doing here. So we have staff here to speak to that particular item, and then just want to take a minute or two to talk about the up and coming Casper health assessment. And so those two items are not on the agenda, but we can talk about them briefly after board training.
Thank you. Any other additions or on the agenda? Oh, great. Now we can move on to the minutes from March 28th. Any additions or corrections that board members might notice? Anything online?
None here.
So being no changes, we can move forward with minutes approved. Any public comment on the minutes? Okay. Thank you. Okay, the next order of business is introductions with new staff and employee recognition.
Thank you, Madam Chair. We do have a couple of staff who are in new positions. So familiar faces, but we would like to introduce them in their new positions. And so, Mary, do you want to start us off with your new hire?
Sure, I'd like to introduce Charity. Charity Middlemiss is our new home visitor. She comes from our WIC clinic. She was the WIC aide and peer counselor for breastfeeding. And now she's our home visitor for parents and teachers, and we want to do it.
Charity, would you like to?
Really excited to have moved over and excited to get out.
And then Julie, you have an announcement of a new hire as well.
So our new Connect Referral and Behavioral Health Data Coordinator is Vivi Tyler. Who also from WIC. She was kind enough to move from the first floor down to the garden level to join us. She'll be working on the Connect Referral system, which after I talked with the board about previously, and we'll be talking again, and then helping with our substance use related project with our.
And I was a work coordinator, so I haven't done this spot, but I'm really excited to start the journey with the strategy team, and I think it's already a thing.
I think they should step and do.
Yes, yes, they are. Well, positions closed on Friday.
Mary is frantically hiring.
Yeah.
So for those of you that are, Jolene just sent me a message saying that those that are in the back of the room are hard to hear. So we might need to come up and speak for those that are next. I'm going to speak a little closer to me. So just FYI. Thanks, Mary, and to the new position. And so hopefully the next time we do staff introductions, we'll have some new staff. And so that'll be exciting. All right, so that is, all for new employees. So now I would like to, take just a moment to honor our quarterly employee. We do this recognition, quarterly, and they are, these individuals who are selected are nominated by their peers within the health department. And we have criteria that range from, just going the extra mile to having incredible teamwork, to really keeping the public health mission kind of at the heart and being very passionate about what they do. And so with this criteria, nominations come in from their peers within the health department and then are selected on a quarterly basis to be honored. And so I would love this quarter to introduce our quarterly award winner, Julie Burke. So Julie, the reason why, I mean, so many reasons, because Julie was really amazing in her previous role as a Connected Growth Coordinator and took on some of the data support functions with many of our grants. She took on systems improvement, which included things like quality improvement. She helped with some workforce development work. She helped us with our health equity work. But the reason why she was nominated, it very specifically, was because she helped us make our way through the very long and painful reaccreditation. She was our reaccreditation coordinator, which was another duty as assigned. So Julie happily said, yes, of course they will help you as the reaccreditation coordinator, but I'm not sure she realized when she said yes to that, how much work that really was. And so future life. Yes, well, so she had to wrangle 10 health department staff because we had 10 staff assigned to the 10 domains for the standards and measures of reaccreditation. She organized and coordinated every other week, monthly meetings. She helped us organize hundreds of documents. She helped us not only organize those hundreds of documents, but then get them put into the format that was required and upload all of those into the system so that the Public Health Accreditation Board reviewers could have access to all of the examples that we were providing them, showing that we're meeting the standards and measures. So I think what I would like to emphasize mostly, though, is that she did all of this work with such compassion and grace and understanding, and she was just so kind to all of us that were really struggling as we made our way through this reaccreditation process. She was like calm waters to help us like move to the next step. Right? We had so many things that we had to do, and she had to help us get through those steps. And so I thank her mostly for being a consistent smile, a consistent help, and just a consistent, compassionate ear when we all were kind of frazzled at the edges with reaccreditation. So I have more to share about reaccreditation later, but this is all about Julie now. And just wanted to say thank you and provide your certificate of recognition for being an amazing employee and such a huge help with reaccreditation. Thank you. Am I supposed to say? Like you're just don't quit.
Can I say, I want to give a shout out to Jolene Helgerson for patiently PDFing documents and trying to understand my logic of page numbers, which didn't always make sense. So thank you, Jolene.
You're welcome.
And for all the people that were involved in reaccreditation. You were all you were all the best cast to heard. Like, like everyone was really great, and thank you, Brenda and Sarah, for listening when I had to vent about what makes sense. And no, it was a great team. So we're gonna go through hundreds and hundreds of documents. No better team to have them.
Thank you for all you guys do. Any public comment? Well, then we can move on in our agenda, to the board discussion.
All right, Madam Chair, members of the board, we have first on the agenda a third quarter fiscal year 24 and third quarter finance report. The board packet has been updated, so the items that we printed and made available here in the room, Dr. McDonald.
Thanks.
And then Heather's also going to share her screen, so everybody can see them on the screen as well. So we're going to go through third quarter financials first. Thanks. So Heather, do you want to bring up the revenue and expenditures page, the summary page first? And we can talk.
Yes, and as we get going through here, this is just our normal what I present to you guys for every quarter. So the top portion of your sheet shows your revenues for the quarter. We're 75% of the way through the year.
Heather,
Yes.
you're not sharing your screen.
Well, why not? How about now?
Yes.
Oh, perfect. Okay, sorry. I'm a little technology yeah, issues over here. So- Perfect. Okay, so the top portion of the sheet is our revenues through the year. We are 75% of the way through the year. So our revenues are sitting at 73%, which is good. We will have a large tax revenues that will come in May. So we'll see another increase in May. The bottom portion here is our personnel. Personnel is actually 77% of the way through the year, but personnel is currently sitting at 71.82%, which is good. The next sheet, and actually this sheet has been updated since the one Brenda printed off. She's going to be a little shocked, but that's fine. Down at the bottom, so these are our expenses. Yeah.
Can we pause and go back to the previous sheet really quick?
Yeah.
Okay.
Go ahead.
Brittany has a question on this one before we move on.
In the interest of educating me, because sometimes this stuff is not, it's not clear. And so when I see under contracts and grants, in the budget remaining $184,303 in the red, but in parentheses, which my understanding is that's under. So we have not received all the grants.
No, that is actually over what our budget was. So our budget was 398,630 for contracts. We have brought in 582,933. So that is just the difference between the two.
Second here, I gotta look at these numbers. So
So it's revenue
it was 398.
is what we projected to bring in revenue from grants.
Okay,
And
and then,
we actually brought in 582.
82.
So we brought in more grant money than.
Yeah.
Like asked.
I'm so glad, this is so, this is such good information, educate. Okay,
So it's what we ended up with more grant funding than what we originally anticipated at the beginning of the program.
that's fabulous. Now, in the next table down, I mean, actual expenditures, temporary seasonal salary, budget is $1,200. I mean, the budget remaining is 17,560. We only had 1,200 in the budget, how can we now?
So we had some grants come in that were not budgeted for, which means we have personnel that was not originally budgeted for. And those personnel had to come out of temporary salaries according to HR. We could not pull them out of regular salaries. So they get pulled out of the temporary line item.
through of the, uncompensated absences, termination pay,
Okay,
which that was unbudgeted as well.
could you say that again? I don't listen as quickly as I should, so I mean,
We budgeted $1,200, anticipating maybe some temporary, but we ended up getting grants that we did not anticipate, which meant that we actually had expenses associated with those grants as well. So that's what you're seeing is grant related expenses that was not covered. Per person.
thank you. I really appreciate your helping me become more knowledgeable how this budget works.
Next year will be better because we won't have a bunch of grants thrown into our mill budget. We'll get to that in a minute. Okay.
Thank you.
Are we good? Is there any other questions?
We're good, Heather.
Okay. So the next sheet is our operating expenses. I will draw you down towards the bottom. They are sitting at 72.77% of operating expenses spent. The lower left-hand corner is the box that has changed since Drenda saw it. So my lovely spreadsheet was not operating correctly. So our 90-day reserve needs to be at 754,000. Our current ending cash is at 646,000. Yep.
Okay, thank you.
Are we good?
So the 90-day reserves is at 754,000.
So the night, in order to be at a 90-day reserve, which is the recommended amount of reserve, we would need to have 750. That's what our limit is. To be at a 90-day reserve, but we're not there. We're at a 79-day reserve. Which is the Indian cash balance. 646,767 and other constructed that on that's our Indian cash balance, which is not quite 70%.
So as you can see on the list, I have. I did prepare for this meeting. I want you to know.
Well, and the one that's in the packet does not include the budget amendments that were approved by commission just recently. So the updated document that was sent out via email and then handed out hard copy here, and that Heather has on the screen. And that does include the budget amendments, which then helps with the questions that you have with negative balance. You know,
Yeah.
the budget amendment that's gonna go through Connor.
Yes. All the CLs.
Yeah.
I was gonna ask about all these things.
And so,
And for the most part, it is,
it's fixed.
it's fixed.
But to speak to that, most of those negative balances that you were concerned about were grant related. So all of that grant revenue that wasn't planned for came with lots of grant expenses that also weren't planned for us. So then we had to go and do budget amendments to fix that, which happens very regularly this time of year. Third, fourth quarter, we are having to make some adjustments to the budget, which you all helped us do because the commission approves those budget amendments.
But what kind of, and I know that you get the grants from the state department, the DPHHS,
That were the federal, but
and they send it out, and these people don't have any way of figuring out how much it's gonna be, and so they just, you know, kind of throw something at the wall.
About to,
It's just. And so then I come along and I think, oh, they're just being messy with their bookkeeping. That's not what it is.
that is not at all. And so hopefully the way we're budgeting next year will help with that. Keep it a little cleaner. The way that we've budgeted up till this point doesn't do a very good job of capturing grants coming and going. Grant budgeting really does need to be kept very separate from our mill budgeting. And so what we're gonna talk about for next year is exactly that, because blending them together obviously causes not only confusion, but it does make it very difficult to track budget. We do it and we do it very well internally, but it makes it really difficult to explain what's happening in this setting. So,
As the county commissioner, I think it is my job to look out for the taxpayers, the people who pay and provide the money. So the grants are not part of that.
exactly,
And
they need to
so-
take that in separate.
And that's, you know, I'm getting better at this.
Yeah.
So thank you, Brenda.
Yeah, thanks
You're
for,
so smart.
and thanks for your patience and understanding with how the last, because this is how we've done it for years.
Sure.
And so now, moving forward, we are gonna do it different based on that very feedback, that we do need to tease out grants so that it is a cleaner, we can look at things in a different way.
Is all county departments going this way? Is it-
Well, yeah.
All
So,
county departments have to do that.
well, our budget in the health department is the most complex in all of the county departments because of the varying types of revenue that we get to do the work that we do. None of the, yes, there are grants that come in, but not to the extent that ours are. So ours becomes way more complicated and we do need to present it differently so that it's clear that grants are very separate than what our local tax dollars.
Come up to the board this morning, and they say, why in the heck do you do it this way? I have no idea. So it's my job to find out. And so I'll be there in the grocery store, explaining to the taxpayers what's going on.
About half of our revenue comes from. And so half of our budget is funded. In other words, like, not all local taxes, we also have the services. That's out half of it. And then I think the other thing I wanted to point out, and then Heather, I'll let you pick back up where you left off. Is on the bottom right-hand side of your expenditure sheet, it shows this time last year, we were setting at a cash balance of $303,000, which is half of where we are now. So our financials are looking much better than we were this time last year. We are in a better place with our ending cash balance. Heather, what else would you add on Q3 expenses?
We're looking good. That's really all I would add. We are looking good. So
And we have, again, Heather mentioned it when we were talking about revenue, but our local property tax assessments come in twice a year, one in November and one in May. So there's a full deposit of tax assessments that you'll see coming in. And we are underspending our budget up by it. So by the end of the fiscal year, we're projecting that we're actually going to be doing really well, and we'll have cash reserves that are looking much better than we were this time.
One of the things about Wilson Park, see is so positive is that they really try hard to have a balance set aside because emergencies come up. We have unexpected flood, fires, we have all kinds of things. So they have this money set aside that is cash reserve. And that doesn't mean they're not spending enough. It's just like their own budget. You know, it's almost they're gonna have a nice job. That's good.
And so it is our goal, of course, to have the recommended minimum gain, and that's what we're showing. Okay, anything more on Q3 meeting? The next item on your agenda is a preliminary look. Preliminary, I'm gonna say it again. It's a preliminary look at,
Preliminary. In before.
yeah, preliminary. So what I want to emphasize is that this is an initial look at the fiscal year 25 budget. It looks a little better than we had a board finance session. Justin and Bree and Brett participated earlier this week in a board finance session where we looked through some more detailed budget documents. So based on that conversation, we took the recommendation of the board members and simplified the budget information down. So that's what you see in front of you. We also because of how complicated previous budgets and financials have been with grants mixed in with our mill budget, we are, instead of presenting you with one holistic budget, we're gonna actually break it into 3 pieces. It is still one budget at the end of the day. But we're gonna look at it in 3 pieces. So the first piece that we're gonna look at is the mill budget. And that's what you see on the screen, and it should be the first page that you all have in front of you. So the revenues in the mill are comprised of our local tax assessments. So people in the county who own property are assessed taxes for lots of different things. One of the things that they are assessed taxes for is health, public health. And so the taxes we anticipate receiving are listed there for you in fiscal year 25 at $1.5 million, or just over 1.5 million. The other revenues that come in to help support the work and do the work that we do in public health come from intergovernmental revenues. And so this is still a couple of grants. But it makes sense to be here because it is paying specifically for immunization services, which is, so these are dollars that will offset the expenses in the mill. They would if we wouldn't have gotten these extra grant funds to do immunization services, they would have been paid for by the mill. So we put them in here as added revenue to do that specific type of work. We also can charge for services and have fines and fees for services. And so what you see there as a total amount of revenues for our mill budget is going to be just over $2.9 million. Is the total amount of revenue we anticipate bringing in fiscal year 20. Our expenses then are simply personnel services, operations and maintenance, fixed charges, which really are rent, technology, and things like that. And then we have to also match or supplement other work that's happening in the health department with these funds. So an example of that, we have to actually very specific items that we have to supplement using our mill, subsidize using our mill funds. The first is water quality or air quality, I'm sorry, our air quality program. There is a required match by the state. So it's a grant that we get from the state and we have to supplement that grant with our local funds. $22,500. The second is our licensed establishment program. That is staff show to the revenues as an expense to the and this we have to show up. It is part of the other financing uses. Oh, thank you. Yep. So our licensed establishment program, we've talked about this a lot this year. We get about $50,000, between $50,000 and $60,000 of fees collected from restaurant owners and spa and pool owners, so forth, licensed establishment operators. That's how much money we get to do the work. It costs us much more to do that work. So we have to supplement or subsidize that work at a tune of $306,335. So the taxpayers are subsidizing business operations by $306,000. And then the third item is our maternal child health block grant, which again, these are federal dollars that go with the state. The state gives them to the locals to do maternal child health work, like home visiting. And there is a 75% required match in order to receive those funds. And so $46,940 of our mill goes to that required match. So that's what those are the three items that are considered other financing uses. And they're expenses that we have to use our local tax dollars to subsidize those programs. Yes, so what you see at the end, at the bottom of fiscal year 25 budget are less expenses than revenue by about $460,000. We are projecting at the end of fiscal year 24 that we're going to be about $900,000, which is over our 9 years. And we built a budget without using our reserve. So we met that goal of balancing our budget without using reserves or county subsidy. And we also met the goal of the recommended 90-day reserve for fiscal year. Thank you, but it's not without significant sacrifice. We are losing staff members. We are reducing our FTE by 5.25 FTE, which is 6 people in the health department. So we are 6 people fewer moving into the new fiscal year than we were in fiscal year 24. We are consolidating staff into this building. So we are sacrificing office space in the city county building. We're sacrificing the environmental health and planning collaboration that happens because they're co-located in the city county building. But it helped us to balance the budget by making sacrifices to personnel, which was our biggest expense. And then we made some other sacrifices like facility. Our IT went down because we did pretty significant work with IT on only paying for things that we absolutely need to have. So there's some sacrifices there. But at the end of the day, we met this. Of balancing the budget without subsidy, without using our reserves, and we met the goal of building back our 90-day reserve, which we had a healthy reserve pre-COVID. We had to use those reserves during the course of COVID because we weren't bringing revenue in that we would. And so we had to build back our reserves. And I believe that we have achieved both of those things for fiscal year 2024. What I will caution us about for fiscal year 25 is that we did get a pretty good chunk of money from the state to help us do immunization services. I alluded to that when I said we have intergovernmental revenues coming in to the mill to help us with that work. We received in fiscal year 24 an amendment that gave us $300,000. And then for fiscal year 25, we're receiving $300,000, but it's short-term funding. That will offset our mill expense for a couple of years. And then we'll be back to a place where we don't have enough money to do the work that we need to do. So for a couple of years, we're gonna look really good, but we need to be very thoughtful and very cautious because a good chunk of that $600,000 or so is short-term funding that the state gave us to help us do that work that normally would be paid for by our tax dollars. Any questions on the mill budget before I move on to there are 2 other budgets I want to show.
Whether it is from local property taxes or largesse from the state. And the executive branch, that money all comes from the taxpayers. And it's just like, we might go out and spend, and then expect the taxpayers, oh yeah, we'll give you an extra. No, that's not good. So you just, every department does this time of year, every department is sitting down with spreadsheets and just taking this all of this. Department of Health is more complex. But it's what we have to do to be responsible to elected and
finish the mission. The book stops here. We have to expand it.
And we are very, responsible with the funds that are given to public. We are, we are fiscally responsible. Any questions on the bill? The next budget are grants. So we tease these out. And so I'm not gonna spend time here. This is money in and money out. Essentially. These are grant funds that come to the health department to do our work. And then our expenses are directly connected to what we have promised to do with these grant funds. Every single grant is approved by the county commission. So, essentially what you see here are those grants that are coming in and being expenses. You see a positive balance here. So we are bringing in just over $3 million in grant funds, and we're spending, less than that in expenses. That balance is because this grant budget includes, behavioral health funds that the county has that we're not spending on. So there's a positive. So we do a lot of behavioral health work that the county supports. And, there is a behavioral health tax assessment specifically. And so those funds come into the county and we are spending some of them, but not all of them. Does that make sense?
If any grant funding in this area, does it allocate where you put that 58,000? Does it allow you to, in the grant, get those grant money?
Those are funds that the county commission will determine how those are used. We are using what's needed to do the work we've been asked to do. The remaining funds are not, we are not determining how those get used. And then the third budget is our water quality protection district budget. So the water quality protection district board met Tuesday. They reviewed this budget. They approved and recommended the budget to the county commission and to the board of health. The district has a very healthy reserve. You can see at the very bottom that says Indian cash. That is their reserve, which is way over 90. They built a budget, fiscal year 25 budget, that spends about $90,000 more than their expected fiscal year 25. Like that $90,000 built in out of their cash reserves. Is exactly what the water quality protection district would be looking to do. So they directed them to spend their reserves down. It was way over 90 days. And they expected a budget to show a negative balance. That negative balance is covered by their very healthy and robust cash. Questions about water quality?
Let's see, how did they get to the expense? Operation and maintenance for 130,000 that you.
Yeah. A big chunk of that is, the way that our prior finance director in the community, helped to, put money into the budget to be used that didn't have a very specific limit. So, she recommended that, we put a chunk of money in contracted services. So that, as the water quality protection district board decided that they wanted to do certain big projects, that they would have money available to do that. We stopped. Heather, would you describe that any differently?
No, that's right.
Any other questions? So this was a preliminary look. Between now and your meeting in May, they will be finalized, so don't be surprised if these change a little bit. I'm hoping that they're not gonna change a lot, but they may change a little bit between now and then as we tighten things up, as we make sure that we haven't missed anything. as we, make sure that, staff is being allocated correctly. Heather is valiantly learning a new system. So she is also going back and just double checking that, the spreadsheets that are coming out are what is represented in the system that she's learning. So again, preliminary budget, you'll get the final budget at your main meeting. And at that time, you'll take action to recommend the health department budget to the county commission.
Can you build that in bold on? Because not as much, but
The final. Okay.
Thank you, Brenda, and Heather, and everybody else. Gave us so much hard luck and had us started to work.
And I just want to say thanks again to Bree and Justin and Rex who kind of muddled through some spreadsheets on Monday that were not quite complete. There was an awful lot to look at and they really kind of, did a really nice job of looking at the full picture of the budget, which is the purpose of the finance committee, is to dig into the details. So.
Thank you. Okay. Are you ready to give us our public health?
Yeah,
Great.
all right. I am so excited to give you this update because we had our site visit 2 weeks ago. Was it 2 weeks ago already? Okay. So after a year and a half, almost 2 years of prepping documents and getting documents submitted, and then our reviewers looking at documents and then getting feedback about those documents and having to readdress documents, 44 of them. We had to readdress 44 of the 400 or whatever we submitted, which wasn't too bad. We finally got to do a site visit. It was virtual, so we had two really that were incredible site visit reviewers from the Public Health Accreditation Board. They are public health professionals in other parts of the country. I don't remember where they were from exactly now. One was from Colorado, and another was from back east. I think. Yeah.
Yeah, I think they were on the performance and. Germany, in North Carolina.
Yeah. Yeah, and so we spent 2 half days, so essentially a full day with the site visitors. And they had very specific questions and things that they wanted to talk to us about. The Board of Health had an opportunity to engage and interact with the site visitors as well. And there were several of you that participated in that session with the site visitors. And then at the end of the site visit, they gave us some, they opened up a few of our standards and measures to readdress again. And there were 8 of those. And so we had 48 hours. Oh, we had they were 7 of them.
Yeah, in 2 different days. We did not, we knocked it out Thursday afternoon and Friday.
So 6 items that they asked us to readdress again.
about
Well, it's out of all of the standards and measures.
So is that 200 or 2,000 or?
Well, there's 55 total, standards and measures, but way more documents than that. But of the 55, 6 of them, they asked us to look at it again and give them some more information. We met their deadline of 48 hours. And then we just got the final report at the end of last week. And so I will, as a follow-up to this meeting, I will send you the full report. It is it's 57 pages long. But of the 55 total standards and measures that we had to address, we fully met 32 of them, which is 58%. We largely met 22 of them at 40, so that's another 40%. And then we slightly met 1 of them, which was 22%. And so we essentially met the standards for all of them. In the report, the site visitors outlined of greatest strengths and some challenges. And again, you'll get the full report, but just a few highlights. They reported that our greatest strengths, based on the documents that we provided as well as the site visits, so conversation, is that our department, it displays strong commitment to the community. We collaborate extensively with partners and stakeholders, and we excel at ensuring that community voice is heard and valued in the work that we do. They went on to say that we have a high level of organization and coordination with our plans and our policies and our procedures. They were really impressed with the way that we do all of those things. They said that a great strength of ours is the engagement with our community health assessment, our performance management, quality improvement, and strategic planning process. So they were happy with the collaborative approach that we use for all of those. A few areas of improvement. They are wanting a more comprehensive description in the future. So when you go to do scanning calendars, what they will be looking for and expecting of us is that we have a more comprehensive description of how commissioners are engaged. Specifically, what level of involvement, the steps that they participated in.
The county.
City and county, we're a city county.
Yeah,
health
okay.
department.
Thank you.
They do. Another area for improvement is our continuity of operations plan. There were some suggestions of how to improve that, and so we'll be working to improve our continuity of operations. It's an emergency preparedness plan that we have. They also saw areas for improvement to enhance our data collection, evaluation, and analysis. To contribute to the overall improvement of community health and equity. So there's some improvement there. Enhancing data collection, evaluation, and analysis that contribute to our overall improvement of community health. And then also establishing measurable time-bound goals and objectives for our community health improvement plan and our strategic plan. So they're looking for improvement in articulating our objectives, measurable objectives, and doing performance management. So those are some areas of improvement. Overall, they were pretty impressed with the way we do our business. They were really complimentary of our Board of Health because of the engagement in the session where they could see that our board understands and supports accreditation and the health department. So that was another highlight. Questions?
Well, I can't remember, he said, but how long is it?
It's a 5-year accreditation. Yep, and we're actually past that 5-year mark by a year. Our 5 years landed in the middle of our COVID operation, and so we asked for an extension. So from when the decision gets made, which the decision has not yet been made, the report of the site visitors go to the Public Health Accreditation Board committee at their May 14th meeting. And at that point, they will make a decision on whether we are given re-accreditation based on the report. So we'll know for sure if we're granting that we. How many health departments in Montana, like what percentage? I don't know if you know, but few. Yeah. So every county has a health department, whether it's a county health department or a city county health department or a district. And one of those in the state as well. It's really just the large health departments. So the Missoula, Great Falls, and Bozeman. Lewis and Clark, and then the state department are the smalls don't have the capacity to do what is required. And so there's another pathway for the smaller jurisdictions to work towards the standards of their accreditation, but in a more supportive and not so nationally, I was gonna look that up. Didn't get around to it. It's a small number. It's a small number of health departments nationally who have achieved accreditation. It's a heavy level. And it's not required. So those of us that do it, we choose to do it. Yeah, it is a big deal. So we're really proud. I'm so grateful for, I'm so proud of this health department because it really did show in this process that we are an excellent health department that does excellent work.
Congratulations.
Thank you. Thank you. Hold on to that.
I know, well, we know you already are, so you can, congratulations, look at another one.
Yes, we will we'll have a celebration and invite our community partners, board of health, staff. So that we can really celebrate. It's a big deal. Any questions on accreditation?
What is accreditation?
What are the benefits of it?
Yeah.
It's a really great question. So, the benefit experienced of being accredited now for over 10 years is that we really can say and know for sure that we are meeting standards and measures that result in better health outcomes for our community. I think that is the best benefit of doing it, the greatest benefit of doing it. I was hoping that when we went through initial accreditation and then through this reaccreditation process now, that we would see some of our state and federal branchers use accreditation status as a way to like rise to the top of the pile for receiving grant funds. We have not yet seen that happen. It might, so I'm hoping that what ultimately not only rise to the top, but if we check the box that we are an accredited health department, then we don't have to do like the hours and hours and hours of writing grant applications that have community assessment in it and all of the things that we do because we're accredited. So, and that we've proven that we do because we're accredited. So if we could knock off 10 hours of grant writing time by saying we're accredited, that would be that, yeah, all things yet to come. The greatest benefit is that the way we do our business, because we're held to those standards, result in a healthy community. So, thank you.
Any other questions?
Like offer if anyone wants to see the manual after this, just have a sense of what that is. I can pull it off the shelf.
Yeah. It's a good 2 and 2 or 3, just that. Standards and measures that we have to. And 2.5 years of hard work. Good. Thank you. Now we get to brag some more. Mhm. So today, we are planning to give the Board of Health an update on our strategic plan. So, the Board of Health has authority in Title 50. It's Title 50-2-116 that gives powers and duties to the Board of Health that directs the work of the health department. And so it is really by law that you all participate in the strategic planning process and then monitor that we're actually making progress on that strategic plan. It's by law that the Board of Health is responsible for that. And so back last year, January, February timeframe, many of you remember participating in a facilitated session where the Board of Health set our strategic initiatives. There are 5 of them. And from that point, the staff within the health department took those strategic initiatives and we drafted goals and objectives, strategies and timelines of how we were going to achieve those initiatives set forth by the Board of Health. The Board of Health then adopted that final strategic plan in April of 2023. So it feels like yesterday, but it was a whole year ago that you all adopted that strategic plan. So therefore, we are here today to give you an update on all of the amazing things that we've done in this past year to elevate public health in this community and to address those 5 initiatives. In your packet, I gave you the full report out of the system that we use to monitor and manage the strategic plan. It is many pages long, and so that's the full detail for you. It will make really great reading one of these things when you want to sit in the sunshine. We are not going to go through that report today, though. We are going to use a PowerPoint presentation that just gives you some really nice highlights of the work that our staff has done in this semester. So Jolene is going to show the screen, and then we are going to tag team presenting the strategic plan update to you all. There's several of us that will participate in this presentation. As a way to just reiterate, this is not a random bandwidth here. This is work that is absolutely done by the amazing team of public health professionals in the team. Jolene, is there any way for you to share the other screen that you're sharing the presenter screen? Would you be able to reshare and share the, or go to the top where it says settings and do presenter view instead of the presentation. Down at the bottom right hand corner, if you use that version of present slides, bottom right hand corner, there's should be a little icon. Yeah, I'll try there. Yeah. Yeah, there you got it. Thank you so much. All right, so year 1, so we call this performance management. It is essentially the highlights of the work that's been done on a strategic plan. Next slide. And so we broke this into the 5 initiatives. So the first initiative is health equity. And so by that, the goals that we set for ourselves for improving health equity across the county is to improve the knowledge of health equity and social determinants of health and build the capacity of our staff and also the community and integrate what we learn into our programs. We also are looking to enhance access to clinical services and make sure that we are not creating barriers, but breaking down barriers for people to access services. Next slide. There to talk about some of the successes.
So the Healthy Communities Coalition, which is a chronic disease prevention coalition, which has been going on for about 19 years. They were listed as one of the leads in our community health improvement plan for the chronic disease section. And those goals were really big and lofty, such as creating an accessible and healthy food system, creating safe and accessible physical activity opportunities, and creating community clinical linkages to prevent chronic disease. So the coalition got a Centers for Disease Control and Prevention grant to help the coalition work through a social determinants of health accelerator plan. So how do we implement chronic disease portions of the community health in a way that has health equity at its core, social determinants of health at its core? And so we got the grant, that was over a 1.5 years ago now, went through the process, created a leadership team, made sure we had interviews and focus groups from people in different populations that we don't normally hear from. And then we created the steps of how are we going to do this for the next 3 years now. And so one example of what came from that plan is offering mammography event in Augusta. So knowing that those in Augusta and the county have to go to Great Falls or Helena to be able to get a mammography. So that's a big barrier. They're taking a full day off of work and probably waiting for better weather and whatever it might take to get to town to do it. There are hospitals that do move. So in Lincoln, it already goes 4 times a year, but it's everywhere. So one of the plans is to talk with community partners, figure out a location, figure out a time, communicate to the public, and do it at least once this year. And if it works, then hopefully it's sustainable. That's just one example of a step that's going on.
Yeah, most of it is involved with and the ground. Is that same figures or is that?
It's not,
Safety.
Thank you.
Using the system.
And we'll do, is that the same as to? Yes. Right.
Thanks, Eric.
yeah, and Pureview's, the reason that it's going on. So.
Well, Fairview has a facility.
We do have a clinic, the perfect clinics in.
But we don't have one in Augusta. From there as well. Or.
Right, next slide, we'll move into initiative number 2, which is all about behavioral health. So we're looking to increase our staff capacity, knowledge, awareness, and understanding of behavioral health. We want to strengthen and expand partnerships and collaborative activities around behavioral health and unhealthy substance use. And then we also want to prioritize our staff wellness and performance. Next slide. And so, we have a couple of staff that will speak to this. Julie and Mary both will be able to speak to some of the highlights.
I'll come up for the microphone. So for the staff behavioral health, knowledge and capacity, it's the first bullet. QPR is a, gatekeeper training on, training folks, lay people to be able to understand, suicide risk, especially in Montana, and ask the question to someone if they are, suicide and response. It stands for the second bullet, we're in the middle of it right now. We have a program called the Lost Team that stands for the outreach to suicide survivors. And there's a cult led with volunteers, not supporting, but really good work is done by some 20 volunteers in the community who are behavioral health professionals and or suicide loss survivors themselves. And that's had some time, about 2 years, whether on me, like, it's provide for support to families after suicide. So we have had a really successful outreach campaign to the volunteers. We had that first conversation tonight. That we have 21 people that previously our English sessions have been smaller with some of that kind of areas we give them volunteers and really inviting them to on scene, so working directly with families as well as families supporting and other volunteers. This is very important. Some new grant funding that was coming. We have 2 new behavioral health staff. One person works on coordinating for local as well as regional with right to share knowledge, resources. That has been involved with that to speak from another person who is part substance misuse is also for familiar with the programs and while working in the substance use from intervention recovery to coordinate with the work and new opportunities to set up into services access.
And I just wrote, my name is not us quite yet. One moment.
I should have wrote myself better note. Thanks. The next slide is all about our third initiative, which is health across the lifespan. And you can see from this slide that this is a robust initiative. This is typical of public health work, right? We're looking to increase the health of highest in our community all the way up to the latest in our community. And so, goals associated with initiative 3 have to do with, making our community age friendly. We're looking at understanding and reducing adverse childhood experiences. We're adopting evidence-based practices around improving nutrition and physical activity. We're preventing chronic disease. We are leading community efforts around immunization and custody programs. We're building community and individual level connectedness, and we're protecting young children from lifelong impacts of life exposure. That's a lot, and so you actually will get 2 full slides full of successes for this particular initiative. And so next slide is the first of 2. And we have Shelley online, who is gonna start us off talking about some successes around HIV testing and some of the work that they're doing.
Okay, hello, good afternoon. So I'm just gonna update you on where we're at. So all the public health nurses this year have been trained and we've performed 22 rapid tests for high-risk individuals, the screening tests that have come into our clinic for one reason or another. We've completed 2 community outreach events offering rapid testing in partnership with Peerview Health Center. We've trained, purchased, and performed 20 rapid syphilis tests. As you've probably heard, the syphilis never was in our community for years and years and years, and now we've had a significant increase in syphilis diagnoses. So this will help us screen high-risk, at-risk individuals to get tested. So we performed 20 of those this year. And that's my piece.
Thanks so much, Shelley. And then you have Beth here to speak about the weather.
Yeah, Beth Norberg, Environmental Health, as well. We received funding recently from Department of Public Health and Human Services, the Childhood Blood Poisoning Prevention Program, to actually expand blood testing for everyone in the super, not just in this one super fund site, and this one is very test, but we also know that using that as well. So we're doing that. We also reinvigorated our Lewis and Clark County Lead Coalition. This is a coalition of various stakeholders coming together to figure out how are we going to engage providers to understand the barriers to getting children tested for lead poisoning. We're planning blood testing events, primarily right now in East Helena, and I'm going to use that template and instead of Lewis and Clark County. And then also gathering that data and that information to show providers in the community really what that lead poisoning is. It sometimes feels really limited. Lead's not an issue, lead poisoning is an issue, but actually is an issue. I'm so working on that.
We're gonna let you take a breather and go back to Shelley on the next slide. And so you can speak to some work that's happening with our WIC program and our child care facilities.
Yeah, so for immunizations, we are collaborating with WIC. They don't right now have a lot of in-person appointments, but their participants, when they come in, we're looking at immunization records for moms, dads, grandma, grandpas, the kiddos, whoever needs it, and we're having WIC will let them know, hey, you're due for some vaccines, and we're right now service. So we just started that process again with reviewing and collaborating with WIC to offer vaccines right when they're here in the same hallway as we are. So we also look at childcare facility immunization records and review those and send notices to the childcare facilities if they have students or staff that are not current to what's required for childcare. We've done 43 of those reviews so far this year also.
Thanks, Shelley.
And we have a partnership with Rocky Mountain Development Council to do their first time homebuyer class. They do that monthly with people buying their first home. So we do education around lead poisoning prevention, what to look for when they're buying a home. We saw that environmental programs in that class, but. Should have done better. Oh, I know, it's okay, we all can.
It gets everybody up in here. The next couple of bullets there are all about our communications campaign. So you'll notice that if you're paying attention to a lot of our social media and the campaign or the articles that go out in the newspaper each month, that they have a theme. And so up to this point, there's been a couple of things specific to chronic disease. One, heart disease, and that happened in February, and then in March, the highlight was around. And then Mary, that's something like,
Yeah, so this year, is simulated sleep format. That our staff can go to the next bit and demonstrate what the person is doing. As well, two of our staff are trained person. Technicians. We look forward to doing our events this year.
right. So that concludes our initiative 3. And so we'll move on to the next slide for initiative 4, which is all about healthy environments. So here we are looking to support local climate change mitigation and adaptation efforts. We are looking to protect the quality and availability of our water resources, and we're building capacity to respond to public health emergencies. Next slide. And so the successes here, I'll have Beth typed in with, I think we haven't, maybe you're-
I'm covering for the water
Okay.
quality board.
Okay.
So, or the water quality district. Yeah, so. You know, well, Amber, our communication specialist, has featured water quality protection district and environmental health. In April, communications campaigns primarily because that's Earth Day is in April, and so really highlighting a lot of the things that the water quality district does. We also, well, I don't know, actually, Amber also attended, I wasn't, but she attended the MPI disaster preparedness.
Now, just so that was a week long, intensive, public information officer specific training for managing water quality. So that was a big success.
Great, thank you. Yes, I promise. But environmental health and water quality district, oh gosh, and a lot of county partners and stakeholders participated in a pretty large flood tabletop disaster training scenario that was in February. And that was really successful and a great opportunity for staff to be a part of. And then between the water quality protection district and environmental health, we've always collaborated and shared information, but we constantly meet. We continue to meet regularly. We do cross-program collaboration. We do not need things to, you know, wells and septic systems are kind of branching out. So we are constantly talking about those things and how to work together to figure out what.
Initiative 5 is our final initiative. So next slide highlights the specific to public health infrastructure. So we're looking to build and sustain our staff capacity, advance organizational structure, positively shift public perception about public health, and then improve data systems and data capacity. Next slide. And so one of the big things, and Dr. Roeder or Valerie, if you're, I would ask them to give this highlight. But in this year, because of this specific goal in our strategic plan, we developed a data council. And that council has in this year completed an entire inventory of all of the various data that we have, that we own, and that we manage within public health. And they created a data management so that not only do we have a good understanding of all of the data that we have, but then how are we managing that and keeping it secure? And how are we using it? And using it is steps. I see you want to talk about statewide advocacy, or should I do this one?
Hi, I was gonna, talk about that statewide advocacy. Is that what you wanted me to do? Couldn't hear you very well.
Yeah, you sure can. Go ahead.
Okay, so the statewide advocacy to increase the license establishment fees in Montana. So MACO is developing a policy statement to reduce the property tax subsidy of licensed establishment programs. So this would increase, hopefully, if it goes through, increase what licensed establishment pays, the establishments pay for the services, and decrease what the taxpayers portion of that is.
Thanks, Shelley, for pitching on that one. The statewide calculations show, I'm trying to do this from memory. But I think the statewide calculations show that licensed establishments, the inspection work that we do is paid for by the business themselves at about 20%. And it's 80% before by the taxpayers. So we're looking at statewide advocacy to shift that a little bit. And that has to be done because it's been statute. And so it has to be the legislators that it is. This one is a really generic staff engaged in high quality professional development, because the list is long. And so what I'll say here is that we take professional development really seriously in public health. It's really important that our staff stay up to date on innovations and most current public health practice. And so we're constantly gaining training and knowledge in lots of different ways, which is building staffing. I will, do you want me to just take these last two? Or? Okay. So environmental health and licensed establishment teams are, they're looking at ways to capitalize and more efficiently use the technology that's available so that there's better collaboration between the two teams. And then the last bullet is really all about shifting that public perception. And so in this first year of our strategic plan, what you've all seen our communication specialists being doing is monthly campaigns that really help this community understand what we do as a health department and why that work is so important. She's also worked really hard to get the people within public health to be better known by this community. And so she highlights individuals that work in public health in our social media so that people in the community can go, oh, it's Sarah, and this is what Sarah does for the health department. And this is, really making it personal to who we are in public health. And then she built a public relations team, which is intended to attend lots of events and things in the community. So we can be talking in different venues about everything. What we do, why we do it, and why it's important for the community to know it. All right, next slide. So it's really important that in all of the initiatives, the work that we do, that we have a real focus on improving the health equity. So these are just a few highlights of ways that we have been able to do that in this first year of our strategic plan. So all of our programs are really looking for ways to identify those high-risk areas in the county, and then we make sure that the people within those high-risk areas are able to access and benefit from services. We have our mobile clinic, which we were very thoughtful about the images that we put on this mobile clinic. We wanted to make sure that the images represented very diverse people in this county. And the mobile clinic is being used to do outreach and to get services to people, because we know that it's often very difficult for people to find. And so we're partnering with Prairie Health Center to get this mobile clinic out on the road and provide services to people that are in need of services. The blood level screening that you mentioned, we're working really hard to make sure that we have screening available to residents of this area beyond just this area. And so they've got their check started. And we are also engaging with our team who's community to develop a sort of looking to the program effectively by really engaging with the government. All right, that is your, we did it in 20 minutes. Nice job, y'all. That's a year's worth of highlights from the strategic.
That's great.
Yes, so,
Do they participate in these home visiting and the programs that our public health department provides?
yes, and we can do a better job. Yes, often it is, individuals from those communities that come to the health department for services. Sarah Halpov is our public health nurse at Augusta. She's built an incredible relationship with the Elk Creek Colony, Wood area. But she is retiring.
Yeah.
So
Health issues.
So we will have to really look at implementing that mobile clinic to do outreach to those across the community. So yes, and we need to do, that's an area of improvement. Populations in this community that we can do better. Any other questions or comments or discussion? Well, and highlights from the strategic plan really don't even capture our day-to-day work. It's above and beyond, right? So if I just went around the room and asked, like, Shelley, what is your daily job? What does it look like on a daily basis? It would be very different than what she just presented to you as highlights for our strategic plan. So it is a lot of work happening and a lot of really good work by a really great team. Bravo. And so we move into year 2. It's a 3-year strategic plan. So we'll keep at it and we will continue to document and report annually to the board.
All right, well, thank you very much. Any public comment on any of the board discussion? Right, well, hearing none, we can move on to our board training.
I kept it.
Oh, thank you. I missed it. Oh, hi, Mary Ann Dunwell. Welcome.
Hi, Officer Neiman and board members. My name is Mary Ann Dunwell. I know most of you. Hi, I'm a state senator representing East Helena and Helena. And I just wanted to weigh in. I was able to hear part, the microphone was a little bit off. Could be my end, I don't know. But anyway, I was able to hear about half of what you were saying. And I just want to again give you a huge shout out. Congratulations on your credentialing and on your many, many successes. I really do hope that at least from the state's perspective, we can find a way to better fund our public health services, even if it's through the money we give back to counties that can be passed on to the Lewis and Clark Health. So thank you and see you later.
Thank you.
Oh, any others, Jolene?
No.
So board training, I tried to keep it brief this time around. So on page 28 and 29 of your packet, we're just going to take a few minutes to talk about Public Health 3.0. So I'm trying to bring training material to you that builds on information, so you as a board can feel like you have kind of those foundational elements of what public health does and how we've done it and kind of the progression of how we've done it. And so, Public Health 3.0, I'm gonna start with just a highlights on, like, what was Public Health 1.0? Where did we start? And so just giving an example, back in the 1800s, Dr. Snow in England, was really trying to figure out why people were getting sick in his community. And so he did that very thing by collecting data or collecting information by talking to the people who were getting sick. He was doing disease investigation, which is what we do today. Both our sanitarians and our public health nurses talk to people who are sick to figure out where they may have been exposed, and get an understanding of where the spread is happening in our community. Dr. Snow was doing that work in his community back in the 1800s. But that was kind of the beginning of public health. And so what he found, they were sick with cholera, which is a waterborne illness, which they didn't know at the time until he had identified the well that all of the sick people had drank from. And then they realized, oh, this is a waterborne illness, not an airborne illness or one that's passed by shaking hands, but it's coming through the water. And so he then convinced the town to shut that well off. And when they shut the well off, people stopped getting sick. And so that was really that's kind of the foundation. That's where public health was born. Was really things like that back in the 1800s, where they were just trying to figure out how to live in more sanitary conditions. You know how important water is and disposal of water, and you know how important our drinking water is, but we take for granted that we can turn on a faucet and that water that comes to fill our water bottles is clean and not contaminated water. But that started somewhere. And we thank Dr. Snow for the work back in the good old days, right? And then we moved into Public Health 2.0, which is really when public health infrastructure was built. Our federal capacity, our state capacity, and our local capacity for public health was really developed between the 1980s and then early 2000s. Much of the work that we did was really foundational public health work, sanitation work, immunizations, vaccine preventable diseases. And a lot of the work that we did was really siloed away from other things that were happening in the community. We know that our healthcare system is so important to community health. We know that schools play a really integral role in making sure that we have a healthy community. We know that law enforcement and churches, like everybody plays this really important role in overall community health. Yet at this time, public health just kind of stayed in their lane. We just kind of did our work quietly. I always joke that we're the wizard behind the curtain. Nobody really knows what public health is, but we, and nobody knows unless something goes wrong, right? Like a pandemic. And then people all of a sudden know what public health is. But it's really in that Public Health 3.0 space, which is early 2000s to now, that we are doing our work in collaboration and in cross-sectional partnerships. It's really pulling lots of partners together and stakeholders together, like we do for our community health improvement plan, to improve the health of our community. We know in public health that we can't do it all. We can do our part, but we can also play a really important role in convening and facilitating conversation. And so they call that term a chief health strategist. And so public health has been called upon across the nation, all the way down to our very small counties in Montana, to be their community health strategist, the chief health strategist. To pull those community partners together to solve big health problems, because we can't do it alone. The health system can't do it alone. Schools can't do it alone. Law enforcement can't do it alone. So we in public health have been tasked with convening, building plans, coordinating work in order to achieve greater health outcomes for the people who live in our communities. So that's where we are now in public health 3.0 land. And and I'm hoping that you saw that come alive in our strategic plan update. I hope what you heard was lots of partnering, lots of coalition work. Not necessarily doing our work alone, but in partnership with Pureview Health Center to get our mobile clinic out on the roads. And in partnership with our pediatricians to make sure that kiddos are getting their lead screenings done. So we're trying really hard to live that 3.0 philosophy. Leading our community conversations right now. There's your board training for the month. What questions can I answer?
I'm kind of surprised that with your statement that the public health 2.0 started in the 1980s.
Yeah, like true infrastructure building with those federal, state and local connected levels.
I guess I was thinking about things like polio vaccines in the 1950s. That was certainly a public health.
Yeah. Oh, for sure. And that's a lot of the public health 1.0 work that's done. Development of vaccines and understanding sanitation, all of that's considered 1.0 public. Nice. Thank you for entertaining a little bit of training each month. I do appreciate that.
Just because we have just a tiny bit of time, I think if you would, just on the spot. What I still remember this when Melanie was here and she was teaching us about public health 3.0 when I was brand new. And kind of going, okay, so if public health is more about the convener and the coalition developer and the leader of that, what role does public health play in filling holes with programmatic? So if there's not, if there's not a nonprofit that's taking on X, activity, like how do you see our community's public health kind of being like catch the net?
Yeah, absolutely. Well, I will use immunizations as a really good example of that. And Shelley's not on anymore, but historically, public health was like a good chunk of the work that we would do is vaccinations. And now you can get a vaccine anywhere. You can go down to your local pharmacy and get a flu shot. You don't have to come to the health department to get that. And so that then allows us to elevate kind of up above the system in which vaccines are being delivered and work across sectors and work across partners to make sure that gaps are filled and continue to provide a service when there is no service available in our community. And so you will always see public health deliver vaccinations, but it looks different today than it did 10 years ago or 20 years ago. And we continue to monitor and then adapt. A lot of times it's because our resources are also at a minimum. So sometimes our decisions are made based on how much money we have available to provide service. But sometimes, like I just described, it's available. And so we don't need to be the single point of delivery. It can be shared among the community, and then we work to coordinate those services so that access is greater. Yeah.
And when we think about emergency management, since one of the positions that was eliminated was Brett's position. And how do you see our ability to be a leader in that area of our community impact?
So this year was kind of a taste test. So last year when Brett resigned and we were having some pretty significant budget challenges, we chose not to rehire that position. And what we did was we absorbed the work into our existing staffing structure. So what that looks like in practice is instead of one person doing public health emergency preparedness work, we have 5 people doing a little bit of, Laurel does a little bit, Shelley does a little bit, Nina does a little bit, Beth does a little bit. And then Laurel is tasked with making sure that that's coordinated and that we are doing it. But it has pros and cons. And so we have to assess whether or not that is the best way to do that work, or if we need to circle back to having a dedicated coordinator. So it was kind of a tester. We pilot tested, having a coordinator this year. And we are in the middle right now of assessing whether or not that's a good thing or not. Because there have been benefits, mostly financial benefit, but we've also seen some reduction in our ability to do all of the robust emergency preparedness planning that we did when going to this. So, yeah. Something good for us as a board of health to monitor. That staffing capacity to do the work is really important, and then balancing it with the available resources. What we're always trying to juggle. Thank you for the training. Any discussion with Board of Health members? Any public comments? Okay. We are now into the additional agenda items, the Horse Creek Hills ruling
I'm gonna
update.
come up here at the mic, closer to the microphone, so
Yep.
people can.
Water, it's probably a jam.
I know, it's my jam. Water. I have a brief, visual you can pass around. I don't know if the people online really need to probably see it. I'll just describe it. And I'm gonna really try to be brief and not go too much into the weeds here. If you haven't heard, there was a court ruling back in February regarding a subdivision in Broadwater County and exempt wells. And so this goes back to a previous court ruling in 2013. Again, Beth Norberg, sorry, environmental health. Goes back to what was called the Sherlock ruling in 2013 that kind of set that standard for development of land in Montana and being exempt from water rights permitting through the Department of Natural Resources and Conservation. So just a quick rundown. When you're developing property in Montana, you typically are running under 3 different statutes. The first one is Subdivision and Plating Act. So that's what the local city and county planning departments do. And they look at a whole, that entire development. So you're looking at roads and fire protection and access and safety. And then of course they take that water and wastewater piece from their DEQ approval, but they also have to take a lot of other things into consideration. We do need to look at water availability, water quality. This was kind of at the forefront with the Broadwater County court ruling in which the county lost because they felt that they didn't do a sufficient enough job with the environmental assessment and really making sure there was enough water for this subdivision. And so if you don't know, the subdivision developer tried to phase in 5, 6 phases, I can't remember how many phases there were, and then claim this phase was, the 10 acre feet exempt wells, all these wells could be exempt. And then they're gonna phase the next part of the subdivision and do exempt wells there. So they didn't have to go through water rights permitting. So this is where then things went wrong and the DNRC gave them these exempt well letters, but then realized, wait, we shouldn't be doing this because there's not enough water for this subdivision. And then there was a lawsuit. So that's the very, very rudimentary part of this whole thing. But that was under that Subdivision and Plating Act, the county commission, planning board, planners, all of those people are involved in that. Then what also works in concert with the sanitation or with the Subdivision and Plating Act is the Sanitation and Subdivisions Act. And that's where us in environmental health, that's where we review subdivisions of water, wastewater, stormwater, solid waste. But for the purposes of this, water, right? We have to look at water availability and water quality. And so we are contracted with the DEQ. The DEQ is the one that oversees that Sanitation and Subdivisions Act. We are contracted to review certain subdivisions for the DEQ. It's a way to let counties review their own work, take pressure off the DEQ. And so we have to look at this water as well. But for us, You know, when I'm reviewing a subdivision, I just, you know, I'm like, okay, do they have that letter from the DNRC that says they're an exempt well use, they're not subject to water rights permitting? Yes or no? Do they have it? Do they also check the boxes for water quality? You know, we have to check the water quality for the area. And do we think, in this little snapshot of time, do we think they're gonna have enough water to carry them through? For this area, we know in the Helena area, we've got areas where there's a ton of water and it's like, we can't give it away fast enough, and then we have areas where there's not water. And so we have to take into consideration when we're, as a contracted reviewer, for their approval for water, wastewater, stormwater, solid waste, do they have enough water? And so that part of that, though, is getting that determination from the DNRC, the Department of Natural Resources and Conservation, and saying, yes, okay, the DNRC says that they will stay under their allocation and they're exempt. That is on hold right now until further notice. So from our perspective and our workload in environmental health, if we receive a subdivision application, and subdivision applications for us could be a simple 2-lot review, it could be a 100-lot subdivision. It could be lifting a restriction on a piece of property that had a previous sanitary restriction on it. It could be someone wanting to change their use. They just want to have 2 houses now on their property instead of 1. And so all of that right now is on hold for us. So we right now are just telling consultants, engineers, those folks, if you have clients that want to go through this process, hold tight. We're waiting on word from the DNRC and the DEQ on what we need to do next. We can get them, what we're trying to do is get them through the process as much as possible. We can still address wastewater, we can still address the stormwater and solid waste piece. We can still look at water quality. We can still look at components of that water portion, but right now there are no new subdivisions going through in the state of Montana until, if they're claiming to be an exempt well, right? If they have water rights, then we can go through that process and look at that if that water right is allowable for that use that they want to do. But right now, all of this is on hold and we don't know yet when this is going to be resolved. It could be up to a year, it could be the legislative session. The legislative session, sure, will get involved in a lot of this. So we don't have from how it's impacting us. It's really just us talking to people who are buying property. I've talked to a lot of people, I want to buy this property, but it has a sanitary restriction on it and I need to lift the restriction and get water and wastewater allowed on this. And I can't because we can't do exempt, we can't claim exemption anymore right now until this gets itself figured out. So it's a pretty big impact. It's not just Lewis and Clark County, it's the entire state of Montana. And we're all just kind of sitting there waiting right now. However, Title 50, which is your guys's, boards of health and the health officers. If we have lots that don't have sanitary restrictions that were never subject to DEQ review, we can move forward with allowing them with local septic permitting. They can drill their well, they can get their water right, they can do those things, but it's that local permitting that they're allowed to do. Yes, that's a lot of our work. I would say even post-COVID, a lot of those lots that people are just sitting on are now getting sold and people are selling those, but those are lots that are typically over those 20-acre lots. Those are bigger lots, our smaller ones that have the restrictions or those that want to give a piece of property to their family member are going to be restricted by this right now. So for us, we're just talking to people a lot. So a lot of our workload right now is just explaining this to people, trying to explain it to them, and just waiting. And so, yeah. Anyway, yeah, any other questions? Yeah.
Yeah, just one more time, around Title 50 and the types of property that this group of people has, any say over, well, the rest is sitting with rules.
Right. So there are the Sanitation and Subdivisions Act, and I'll go back to that because it was created in 1961. So we have a lot of lots in Lewis and Clark County that were created before 1961, little 1-acre, 2-acre tracts, whatever. We also they changed it over time from 5 acres to 10 acres and then the 20 acres. So 20 acres is that exemption. You can take any 20-acre lot you want right now, develop it with water, wastewater, and not have to go through the Sanitation and Subdivisions Act in that part of DEQ. So it would just be Title 50, right? So anything over 20 acres or certain lots that were created prior to legislative changes over the years. Those are the lots we're talking about that we can take them through, environmental health can go and take them through that process. There are certain things though that you can't do on properties over 20 acres, no matter what, and that's RV parks and trailer courts. So even over 20 acres, you want to do a trailer court, you still have to take that through the Sanitation and Subdivisions Act, and get that DEQ approval. They will be on hold as well. So for the most part, everyone else can, but there are a few exceptions. So we can get those through, you know, our process is about 30 days, start to finish, to get something approved on one of those lots through Title 50. But if it does require, like if it had a previous DEQ approval, that's called a rewrite. Someone has a previous COSA for a lot and they want to now add that second house. I've noticed a lot of people want to develop lots with now a second house for their family member or for someone or rental opportunity. And if they already have a DEQ approval that says it's only for one dwelling, they have to take that back to DEQ. Therefore, they need that water rights exemption letter and they're not going to get it because that's on. So we can take them as far as that and then sit on their application. Yeah, it's a big impact. It's been a big impact. I mean, for us, I think we haven't seen applications coming in the past couple of months because of that. I think consultants, engineers, people preparing these applications are also kind of sitting on them and waiting. And they're frustrated too in private industry, not being able to, you know, make their income that they need to make, and people want to develop and they can't.
And then at Water Flood and Protection District meeting this week, there was a gal there who did a really nice job of complimenting Wilson Park County in particular for all of the work they did around planning and zoning. Because that, the fact that our county has done that work will help kind of move into the future of what this is going to look like. But we still are having to wait on Department of Natural Resources, so DNRC, and Department of Environmental Quality. They have to make some amendments or adjustments to their administrative rules in order for things to continue to progress forward. So our county plays a role in that too, but sounds like we are sitting pretty good because we have decent rural planning and zoning standards in place.
Yeah, and our county planning department has a whole nother set of their, you know, roadblocks with this. When they're looking at subdivisions and they're gonna have to, you know, review these. Now, water quantity and this exempt well issue, I mean, they're kind of the same, but they are still different. So just because you have exempt wells here, county still have to look at availability. And, you know, we know that this has been a burden, but we also do know that lots, if you don't have water, you don't have water. What good is the house you have if you can't turn that tap on and have clean, reliable water supply, like you were saying earlier? So there's that piece that, you know, I mean, we want people to develop, we want housing, we want these things. We have to do it smart, and we have to make sure there's enough water to go around for everybody too. So
This may be a silly question, but does that hold some of the development that's already occurring right now?
no, it should not hold them, because if they have that approval, if their subdivision has gone through the plating act and the county commission has approved it, if the DEQ has approved, well, a little bit, the DEQ approval, so the DEQ reviews it, they say, you have enough water, you have your exempt well letter here. And then they go to, they need that for preliminary plat for that subdivision through plating act, right?
Yeah.
So it's a little bit, then the county commission, planning board, you know, they look at it and go, okay, part of the subdivision application is we have a DEQ approval, so it should be fine. We have the DNRC saying there's an exempt well, it should be fine. But I think you're gonna see planning departments start to be a little more observant of water availability and making sure that there is going to actually be water in the long run, and not just that snapshot of, we went and did aquifer pump tests and it was fine, but really look at the future. And I think a lot of this lawsuit tried to encompass that. It's complicated, but you'll see planning departments start to pay more attention.
There's probably gonna be activity during the session next year.
Very much so.
If you're interested in this topic whatsoever, my guess is that they'll take it up during.
They will take it up during the session. We kind of heard a little snippet, and that's why we're not sure about our time frame. We know DEQ, DNRC, they gotta do rule packages now. They gotta do administrative rule packages. Those are not easy things. So they have to do that, and then they have to, but then when the legislature gets a hold of it, we'll see how it goes and which way. Yeah.
Thank you.
Yeah, you're welcome. Thank you.
Our resident expert.
Well,
Yeah.
I appreciate you.
yes.
The Casper Health Assistant?
Yes, so, I emailed the Board of Health with some information and then it hit the news this week too. So I wanted to take this opportunity during board meeting to just, let you all know that the health department in cooperation and collaboration, keywords, with Pureview Health Center, St. Peter's Health, United Way of the Lewis and Clark area, Rocky Mountain Development Council, we are, will be doing a door-to-door collection of data on, around health topics at the end of June. Not just in Lewis and Clark County, but it's gonna be a 5-county approach. We are looking at recruiting volunteers for specifically Lewis and Clark County. We need 30 teams of 2. So we need essentially 60 volunteers to help with just the Lewis and Clark area. And then also Broadwater, Jefferson, Marr, and Powell counties are doing this as well. And so most of those, all but one of those counties are able to recruit their own volunteers to do their areas. But Powell County is asking for some help, so we're gonna see if we can help them recruit some volunteers to help out in Powell. At the end of June, our day is the 25th, so Lewis and Clark County will have volunteers go out to really specific areas, neighborhoods, for example. Both in the city limits as well as throughout the county. So in some cases, we'll have volunteers that will go up to the Augusta area. So they'll make a trek all the way up there. It'll be beautiful. It's one of my favorite places is up on the Rocky Mountain front by Augusta. But we'll cover the entire county, go to neighborhoods, and there's some methodology of not every house will get knocked on, but every 7th house or so. So there will be training on how volunteers will go about doing this. The team of 2 for safety and also just logistics, knock on the door, ask questions that are really trying to get at the heart of the health of our community and the health of people who live in this community. They'll gather that data. We're looking at the survey being no longer than about 15 or 20 minutes. So that's the amount of time we're asking of residents of the county. We're gonna do $500 gift cards. So those that do participate, their name will go in a drawing for a $500 gift card. Volunteers will be identified by vests and ID tags. We're gonna do a lot of promotion across the community to let people know that this is what's happening. So as volunteers go out, it won't be a surprise when people are knocking on doors. Gas will be reimbursed. They're actually going to be given gas cards. Volunteers will be given gas cards to help offset the expense of going out into the community and driving around, especially to Augusta. Yeah, the training will be several hours. It's a robust training that all our volunteers will get prior to going out. So if you're interested, there is on our website, and I also included it in the email that I sent, a link to our volunteer application. So if you're interested in participating in our door-to-door efforts, and I do encourage you to fill out the application and join us on the 25th. We will start training about 11:30, 12 o'clock. Couple of hours of training and then really launching out into the community about 3 o'clock. And we hope to be done by 7:30 and back to home base, get everything turned in and be done by 8 o'clock. So it's a pretty full day of both training and then data collection. But this is the methodology that we're using is based on a survey that's done nationally. It's called the CASPER, and it's the Center for Disease Control and Prevention that, they are helping us and guiding us through this. And so it is a valid and reliable way of collecting information and a really great way to have some FaceTime. So we're excited about that. What questions? Do you want to add?
I was just gonna say, general nursing student,
Yeah. If you're gonna be around.
in public health initiative, so. Some of them.
This is the year that we are updating our community health assessment. So by December, we will have a brand new, fresh community health report with lots of data. And one of the data sources will be this door-to-door data collection effort. And then, of course, we'll gather data from other secondary sources like the vital statistics and, lots, CDC has a lot of data that's available. We're only asking questions during this door-to-door survey and collection effort that we can't get anywhere else. So there's questions, we did a lot of, Dorota did it actually before she left here. Did a matrix to make sure that the questions that we want to ask we don't have access to that same information anywhere else. So it should be very, very enlightening for us to collect this data and then use it as part of our community health planning. So this year, we'll collect the data, put the report together. By December, we'll publish the report in partnership with our Healthy Together steering committee. And then next year, we'll use that data to do another iteration of our community health improvement plan. So this is a big year for data. So I hope that you're all open and willing and excited to get out there and join us. That's what I have for you.
Well, thank you. Do we have any public comment on any areas that we have talked about on the agenda?
I see none.
Really?
Thank you.
Right on time. Not on time. I love it when the plan comes together.